Um, uh, Profesora Hristova, thank you very much for inviting me to Dni na ehokoreografijata 10. jubilarno izdanje in Sofia. And it's my pleasure to present at this esteemed seminar. And I'll try to pronounce this my presentation in Bulgarian. Ehokoreografijata pri TAVA usložnjenja, or echocardiography for TAVA complications. So let me start with my disclosures. They're listed here. And I'll start with the rhetorical questions. As echocardiographers, are we still needed for TAVA procedures? Maybe we should not. And you look at the imaging for any structural procedure, including TAVA, there is a pre-procedural, intra-procedural, and post-procedural imaging. And echocardiography plays a key role in every element and every step of this procedure, whether pre-procedurally, intra-procedurally, and post-procedurally. And I'll share with you mostly intra-procedural imaging because the topic is complication of TAVR. If you then look at this, whether pre-procedural, intra-procedurally, what kind of echocardiography we will need, it's primarily transthoracic echocardiography. Transesophageal echocardiography is rarely needed either for preoperative evaluation for TAVA or intra-procedural imaging, as I will show you in a moment from our own institution. But a CT plays a key role in transcatheter valve sizing as well as assessment for vascular access for the TAVA procedure. In my own institution, we have been doing for more than a decade, TAVR. Last year alone, we did 500 native valve TAVRs. And as you can see, we have done more than 98% of those intraprocedural imaging was done with transthoracic rather than transesophageal echocardiography. And if we do transesophageal echocardiography, it's primarily for alternative access, such as subclavian artery access, or complex procedures such as tearing of the prosthetic valve or native valve in the basilica procedure. And just briefly, just show you what the current TAVA valves are, either balloon expandable, which is primarily Edwards Sapien family of valves, and on self-expanding is primarily Medtronic core valve, and then an Edwards Navitor valve. But the self-expanding with the one or the other have a similar principle that they will do it. And I'll just show you that if you have no balloon expandable Edwards Sapien valve, fluoroscopically, you might start with the predilation of the valve, and then there is a balloon expandable valve that it's really just delivered, expanded with the balloon, and that's it. And then after we position, we will then inflate the balloon and deliver the valve. So the echocardiographic evaluation for normal or abnormal function for complication will occur only after the valve is fully deployed. And if we are not completely satisfied, sometimes we might do post-procedural post-dilation. And then this would be transthoracic echocardiography, how that Sapien valve, it's a relatively short, less than 4 centimeters, and it's an apical 3-chamber view, and we can detect with the color or other elements of echocardiography to see the function or malfunction of the installed prosthesis. As opposed to self-expanding valves, they tend to be twice as long or twice as high. And the native visualization, again, we may do predilation, not necessarily, but the advantage of these that could be partly deployed to test the function of the valve and as well as the seal before we fully deploy the valve. And therefore, echocardiography is much more important in this type of valve because we can evaluate and even guide. The next step is the procedure, depending how well the prosthesis is placed. And then if we are not satisfied, then we can go to post-procedural dilation. So these are the basic procedural steps, and let's see how the echocardiography plays a role there. So echocardiography, this is a parasternal long axis view, and you see that it's a much longer prosthesis than balloon expandable one. And again, we can use all tools in echocardiography to test the function of the valve. And now what the talk is about the complications. There is a variety of complications which I can divide into 3 groups. One is the prosthetic malfunction, that a newly installed prosthesis is not functioning as it's supposed. And then there are complications within the heart that are not directly related to the function of the prosthesis itself. Let's call them cardiac complication. And finally, there are vascular complications, anywhere on the path of the delivery system from the typical femoral arteries all the way to the heart itself. And then on a valvular malfunction, it could be prostatic regurgitation, prostatic stenosis, or prostatic embolization. On a cardiac complication, it could be perforation of either ventricle, which is luckily very rare. And then we can have rarely disruption of the mitral valve through the procedure, typically by the support wire. And then left ventricular dysfunction, whether coronary obstruction or suicide left ventricle. And vascular complication could be at the access site. There is excessive bleed, hematoma, pseudoaneurysm, aortic complications from the rupture to systemic embolism, and finally coronary complications with the ostial obstruction or embolism from any part of the system that the delivery passed through. So, but it is really a complex and a fast-paced procedure, so we then have to have a simplified way to assess the function of the valve. And this is what I propose, something called the SVS trial, or seal velocity shape. It's a play on the word of STS trial, which is Society of Thoracic Surgeon scoring skills similar to Euroscore. So let's see what that is. So it's a rapid intraprocedural echocardiographic method to assess the TAVR success. And what are the markers of good implantation? And that's the first. S is for seal. There should be no significant paravalvular or transvalvular aortic regurgitation. V is for velocity, and that we see that the typical velocity post-implantation of a prosthesis is less than 2 meters. And then valve shape in the short axis should be as circular as possible, and the long axis should be neither too deep or neither too shallow with respect to aortic annulus. And why that is important? Because if we see in the procedural, particularly with the self-expanding valve, we can then guide interventionalists whether to reposition the valve, post-dilate the existing valve, or God forbid, need to place yet another valve inside the already installed TAVR valve. So let's look at how in the real life that it's. The S for the SVS trial, for the seal. For instance, this is a self-expanding valve, apical 5-chamber view, and you see there is a minimal paravalvular regurgitation, and often in a self-expanding valve, this appears within 24 hours. And then you can change any view from apical 4 to apical 3-chamber view, and again, assess for a seal. Go parasternal long axis view, again, and a short axis. So now these are the 4 key views, and then we can then decide that it's really a seal in this patient is good. So now, however, if you look at another case, which is really rarely seen now, and I have to dig my database to find these cases, it's to see paravalvular regurgitation. This is apical 5-chamber view, and you see there is a significant paravalvular. And if you're an imager, it's very important to rotate the probe, to sweep the probe, to see the frame rather than the open channel of blood to visualize the paravalvular regurgitation. And then you can see multiple views. Now switching to apical 3-chamber view, again, it's a sweep. So to show the frame of the valve and show the complication, which is paravalvular regurgitation. Then if you look at the parasternal long axis view, this is clearly the reason for the paravalvular regurgitation is the seal, which is on the caudal end of the prosthesis, is actually prolapsed into the left ventricle. So the prosthesis is too deep and therefore naturally cannot seal. And if you put the color, again, with the sweep, there is a significant paravalvular regurgitation. That it's probably most common complication, if you could call it, on the valvular malfunction of the TAVR valve. And now in this patient, we would say that the seal is not good. We can also look at the simultaneously fluoroscopically. This is partly deployed self-expanding valve. And now on fluoroscopy, you can actually see that there is a significant, the valve is deep. And because the deep, there is a significant paravalvular regurgitation. How to quantify this paravalvular regurgitation is not easy. Way to grade it, there is something called the VARC 3 criteria, an expert consensus without empiric validation, but the most commonly used the percentage on involvement of circumference in the short axis, and if it's more than 30%, it will be considered severe. And this would be an example how you do that. This is a short axis at the annular level. We see the paravalvular regurgitation, how severe. We will stop the frame, and then we just put this X, and then each part is 25%, and this is about the 25% involvement of the circumference. So there we would say this is moderate to severe paravalvular regurgitation of a TAVR valve. So also it's important to look at the spectral Doppler. This would be a spectral Doppler of mild aortic regurgitation. However, if you see this, it's really rapidly decelerating jet of aortic regurgitation. It's a sign of severe acute aortic regurgitation, and it's really badly tolerated. It's an important complication, and it typically due to significant paravalvular regurgitation. And if you look at the abdominal aorta or suprasternal, you look at the descending thoracic aorta, there will be holodiastolic reversal, which is important to notice. That might be a new. If it's truly new, that it's a sign of severe aortic regurgitation, an important complication of TAVR valve. And there are really guidelines, both American and European, that you can see this. So now let's look at the V of the velocity of the valve. So this is what you start with. The baseline is a severe high gradient aortic stenosis with the late peaking gradient. And when you put prosthesis, miraculously, immediately, that stenosis turns into a normal velocity with the early peaking triangular shape, parabolic shape became triangular shape, late peaking become early peaking. And let's look at how that will say that the velocity is good if it's less than 2 meters. But however, if I look at this case, velocity is 2.6 meters. Now you can say, is this normal or abnormal? Is this a complication or not? But at that you can say that depends. If the left ventricular outflow velocity or subvalvular velocity are also elevated because the ventricle is hyperdynamic, then this could be acceptable even if it's above 2 meters. However, if the subvalvular velocity is normal or low, then you have a DVI or dimensional velocity index that it's very high, then this is completely abnormal, and this 2.6 is really a sign of either underdeployed valve or something's wrong with the prosthesis. So in this case, we will say that the velocity is not good. And this is underdeployed TAVR valve, undersized valve, or TAVR valve has migrated. In this case, it was the underdeployed TAVR valve, and then the solution is a post-dilated valve. How about this case? So this is a pre-TAVR valve velocity, aortic velocity was 4.3 meters, consistent with severe high gradient aortic stenosis. Immediately post-TAVR, it's expected decrease in velocity to less than 2 meters, early peaking, triangular shape, and then within minutes, the velocity jumped to 4.5. And you can just question yourself why this might be the case. But it's essentially what happens, and I'll show you on fluoroscopy. This is immediately post-TAVR. It's a valve is deployed. Seemed the velocity should be okay, but then minutes later, the valve migrated. This is balloon expandable valve migrated or embolized into the ascending aorta immediately. So the velocity returned to the clear baseline. And just to show that this is not a characteristic of balloon expandable valve, but the self-expanding valve, the same can occur, and these spectral recording could occur from either valve because both can embolize. So recognizing the velocity change is an important sign that the valve might have migrated and created a complication. And now let's look at the shape of the valve. So this is ideally in a short axis, the prosthesis should be circular in shape. However, and also in the long axis, that should be neither too deep, neither too shallow relative to the annulus. So this is how it's really should the properly placed self-expanding valve will be. The exact position depends also on the size of a membranous septum to avoid damaging the AV conduction system. So in this case, we could say that the shape is correct, circular, neither too deep, neither too shallow. How about another case? This is several months. This was not intraprocedurally, but the several months. This is somebody had the transesophageal echocardiogram. It actually was done for evaluation of the mitral valve, but it is native mitral valve. But we took opportunity to evaluate the aortic valve, which was here. It's a self-expanding valve, and actually see that the velocity is at 3.5 meters. It was clearly abnormal. Let's see why that is involved. What kind of complication this? If you look at the shape of the prosthesis, you can clearly see that there is a constrained self-expanding prosthesis in its caudal end. And if you turn into the short axis, you see this is clearly abnormal. This is nothing circulates. It's highly ovoid prosthesis. And once you have ovoid prosthesis, there cannot be a good seal. So therefore, paravalvular regurgitation is present, but also will be elevated gradient because the prosthesis is not fully expanding and creating now iatrogenic aortic stenosis. So in this case, we would say that this is not a good shape. What's the solution for that? Is a post-dilation of the prosthesis. So why do people have elevated intraprocedural gradients? I'll show you another complication. Krasimira, I believe I have a few more minutes. So this is, I'll show you the 94-year-old woman is undergoing transfemoral TAVR using a balloon expandable transcatheter valve. And I'll show you prior to TAVR, this is through the aortic valve, velocity is 4.5 meters. It's a high velocity or severe aortic stenosis, and then through mitral valve, the velocity is 7.8, which you would expect in somebody with severe aortic stenosis. So this is what happened before TAVR. And now after TAVR, you see that through the aortic valve, now velocity is 5.2 meters, but the shape is very different. It's no longer parabolic, mid-systolic peaking. Now it's a late peaking, very high velocity. And also the mitral regurgitation is also very high velocity that indicated that there is an obstruction to the left ventricular outflow, but it's also very late peaking. So this is an important complication to recognize. So which of the following is the most likely TAVR complication visualized by transthoracic in this patient? So you might ask your questions whether this is severe paravalvular aortic regurgitation, whether this is severe mitral regurgitation due to chordal rupture, which is a possibility, whether this is a suicide left ventricle, or whether this is underexpanded TAVR valve. And while you're considering, I'll show you before and after, and you might decide what the correct answer. But I'll tell you it's a suicide left ventricle. So what is the suicide left ventricle? And when you have somebody with a combination of both subvalvular and valvular aortic stenosis, and when you relieve the fixed aortic stenosis due to TAVR, then all of a sudden you uncover dynamic left ventricular outflow obstruction due to systolic anterior motion of the mitral valve. And this typically occurs if the pre-existing ventricle is small, very hypertrophied, and also if there is a significant mitral annular calcifications. And then I'll show you quickly how this now I clearly see that this patient post-TAVR develops systolic anterior motion. There is really anterior leaflet is hitting the septum. There is mitral septal contact. And then if you look at the color, there's a typical Y sign or inverted Y sign where there is a simultaneous obstruction of the LVOT as well as new mitral regurgitation. That it's really systolic anterior motion, nicely seen. It's a Y sign. And the first actually described that it was previously described for a pulmonic valve by a pediatrician, but then by Palacios at MGH described that many years ago for the left ventricle. And then what do you do that? It's a suicide left ventricle. You really prompt treatment with beta blocker, left ventricular pacing, or alcohol septal ablation. So Krasimira, I believe I have spoken for 20 minutes. Would you like me to show one more case, or should I complete presentation?
Yes, the public here is one more case, if it's possible.
One more case. Okay,
Yes.
excellent. Thank you, sir. Thank you, Krasimira. So how about this is a very unusual case and a TAVR embolism into the left ventricle. So this I'll show you a case presentation. This is 59-year-old man referred for possible transcatheter aortic valve in homograft procedure, a form of TAVR procedure. So we typically do in a native valve. We can do for failed surgical prosthesis, but in this case is a homograft in a patient, and we opted for valve, transcatheter valves, essentially TAVR in a surgical homograft. So he was born with the bicuspid aortic valve. And age 38, he had the type A aortic dissection and underwent first surgery, which was a valve-sparing replacement of the ascending aorta. And age 47, he had aortic root aneurysm with aortic regurgitation, underwent second surgery with aortic root replacement with a cadaveric homograft. And now at age 59, there is a recurrence of severe aortic regurgitation and LV systolic dysfunction. So this has an indication again for surgery. He was, another surgery, it will be a third surgery was considered, but was too deemed risky from the surgical perspective, and the patient was not very keen on having to have it done. This is his CT, and you see the complex surgery. There is a homograft, there is a tube graft as well, and then there is a residual dissection in the aorta. So this is a really complex case. So this is now you see the significant calcification in the region of the surgery, which we felt that will be enough to hold the TAVR valve. This will be a off-label use of a TAVR valve in the homograft, and we do all the sizing by CT, that the same way we would do it for native valves. So as a heart team, we sat down and then we decided that we will do the aortic valve in homograft using 29 millimeter SAPIEN S3 balloon expandable valve. And so this is the valve, as I showed you previously picture, but this is annular seal on the caudal end, and then you see prosthetic leaflets. But I also want to point attention to you to see there are metal diamonds of the frame, but you see on the bottom, these diamonds are smaller than there are on the top. So these diamonds on the top are much bigger than the one. So you'll see that might be important when I show you that. And now we'll show you the intraprocedural fluoroscopy, just as we did. You see the wires of prior stenotomy. So we deployed the valve. So that valve looks good. And we deployed it. We are very happy. The patient is happy. And you see the diamonds, the big diamonds are cranial, little diamonds are caudal. So we are happy, the patient is happy. And let's see, rapidly do SVS for this patient. So this is, and remember, I showed you what are the reasons of SVS, and let's do this for patients. So we look at the apical 5-chamber view, and we say seal, beautiful. There is no paravalvular regurgitation. We are happy. The patient is happy. We are looking at another view, parasternal long axis view. There is no paravalvular regurgitation. Seal is very good. We are happy. Patient is happy. Now we look at the velocities. Velocities through the new TAVR is 1.2 meters per second, less than 2 meters. So this is very good. So we are happy. There is a velocity criterion. We look at the short axis for the shape. It is as circular as it can be. So we can say shape. So we have all of this. We have successfully placed TAVR valve in the homograft. And so the next day, so we do this TAVRs one day. The next day, patient goes home, and patient was feeling great. We are feeling great, and he was ready to go home. And then suddenly he collapsed and has a pulseless electrical activity, or PA, arrest. Maybe we thought maybe he has a pulmonary embolism or something. So then we look at the chest X-ray. This is at the time of the arrest. And if you actually really pay attention and compare it to before, day early, you will see that on the day early, that the position of the prosthesis is correct. You see the big diamonds of the shape are cranial and the little diamond are caudal. But now at the time of the rest, you see that now it's upside down. So the big diamonds are caudal and the little diamonds are now cranial. Wow, what happened? Let's see this. So this is immediately the resuscitation. We even have a CTE. And now actually see the LVOT, you see the prosthetic valve, but see that the leaflets are upside down. So that the prosthesis is upside down. These leaflets of the prosthetic should be on the other side of the LVOT. And then now, if you look at the in a long axis view or the LVOT view, now you see to the right side of the image, you native valve, a homograft valve of the surgery on the top, and below in the LVOT is the TAVR valve that it's upside down. So the patient has two valves that are contracting in the opposite way. That's a homograft valve, and this is SAPIEN S3 valve. And now actually you can see that there is a flow for this. And the only reason actually this patient survived is there is a significant paravalvular regurgitation that provides the blood. And then this is, if we look at this is now in the transgastric view, you will see that, again, the prosthesis is upside down. So now what happened to the patient's SAPIEN valve one day after successful one-in homograft procedure? So this is now, you can actually see that this is upside down SAPIEN S3 as opposed to homograft aortic valve. And again, as I showed you, it's really flipped upside down. And that's essentially normal to happen if the valve drops into the left ventricle, then it becomes a sail. It naturally flips itself up, and then the leaflets become the sail. With the systole, they will be ejected into the LVOT. And that's the explanation. Sapien S3 properly placed right side up on the day of the procedure. Next day, Sapien S3 likely lost anchoring in the homograft annulus and dropped into the LVOT. So Sapien S3 likely tumbled inside the left ventricle and then became upside down. So at the epilogue, so patient was promptly brought back to the hybrid OR, and that's T that I showed you, underwent another valve-in-valve procedure. So now he has a Sapien S3 in core valve and Sapien S3 in homograft. So I hope you enjoy it, and thank you very much. Благодарим. Krasimira, I don't think I hear you.
There is no question on the audience, and I will give the short presentation from the Professor Tuğba Kemaloglu, which is the president of the Global Society of Cardiology, to invite the next speaker and to present the next speaker. Tuğba.
Question for Mohammed Sarik, and I want to say thank you to Krasimira for this great organization and collaboration and all your contribution to Global Society of Cardiology. I appreciate it. And Dr. Sarik, amazing presentation. Actually, I'm impressed, especially last case was amazing. I'm shocked still. I want to learn your opinion about 3D echo, especially pre-procedural evaluation. Do you use it?
Of echocardiography with the CT imaging pre-procedurally. And we have to be honest, I love echocardiography. I do CT as well, but truly is the workhorse is really CT pre-evaluation. Do we use 3D transesophageal echocardiography for sizing? Yes, and occasionally. And that occurs if the patient cannot undergo CT imaging. And that's typically if they have renal disease or for whatever they cannot receive or they're allergic to contrast, then we will do, and I have a whole presentation on how to do that. And essentially we do 3D imaging of the aortic valve, but transesophageally, and then we can do the same multiplane reconstruction imaging to size the annulus and all other parameters. Are we as good as CT? No, but if we can't do anything else, then the 3D echocardiography really helps and saves the patient from not undergoing the procedure. I hope that answers your question.
Yes, exactly. Thank you so much. And I completely agree to you. And I want to introduce my dear friend Ritu Taman from Pittsburgh University. She is board member of Global Society and very famous cardiac imager. And we are going to listen the role of echocardiography MRI for mitral regurgitation evaluation. Yes, we are listening to you, Ritu.
Hello, everyone. Thank you so much for this kind invitation. I'm so honored to be here with you all. Now, we are going to be switching gears, and we've just had a tremendous presentation from Dr. Sarik. Now we are going back to bread and butter cardiology, how to quantitate mitral regurgitation, which we do because A, we need to have a clear assessment of how the MR is progressing so we can communicate with our surgeons, we can communicate with our patients, and give them a numerical value. And that has clearly been demonstrated with regurgitant volume over time, not so much for color, Doppler, jet area. And we have substantial data on EROA, both for primary and secondary MR, and the guidelines give us these angiographic grades that were mild was angiographic grade 1, severe was 4, moderate is 2 to 3, and we have severe cutoffs as being 60 in terms of the MR volume and 0.40 for the effective orifice area. So how do we do this? Most commonly, we use PISA. Now, the first principle is that blood is incompressible. It is not like oxygen. Blood is not compressible. So therefore, flow is the constant. And we use that fact when we look at flow convergence, which is this phenomena you see here, whereby you have hemispheres of flow divided up in increasing velocity. So the area, it's still a concentric hemisphere. That area becomes smaller as it approaches this infinitesimally small hole, but the velocity increases. And we take advantage of this physiology and nature and figure out what the PISA flow rate is, and which is the hemispheric area times the velocity of the aliasing flow. And it is always the same. Flow being constant is always going to be your area times your peak velocity. And so this is what we're trying to accomplish. And the first thing you need to do is keep your color on and zoom in as tightly as you can, because we need to see what we're doing. And when we look at the color bar, which is a velocity, average velocity map, we're looking to see where the color changes when it reaches the Nyquist limit, right? And so we're looking for it to change from yellow to blue, and that tells us that that's where the aliasing is happening, and that is what we need to measure. Now, we are talking about a hemisphere, but the good shape is actually a ball on top of a jet. Is that? It's because of the Doppler effect. So when you are at 90 degrees, your Doppler, your cosine is 0. So you're going to see black. You're going to have no flows. And that's what we see in the indentation of the vena contracta. So here you leave your color on, you stop it at the T wave, which is mid-systole. You look for the aliasing interface between the yellow and the blue. Whoops. And then you measure that radius down to the neck of the vena contracta. That is your radius. And you look to see what is your aliasing velocity. Now, we want to have the perfect shape. Now, the first one here is too long. It's like a watermelon. And here the velocity is 19. I increase the velocity, and so my shape becomes smaller, but it's still a little bit too long. And then I increase my aliasing velocity one more time, and then I'm getting a much nicer ball on top of a jet. And that is where I should be measuring ideally. And this is very important to remember. But as you all know, PISA does have its pitfalls. And so when we have secondary or functional MR, your orifice is not is flat, and it's not a hemisphere. It's more a concentric shape, and you see your PISA is going to be flattened, and therefore you're going to underestimate your MR velocity. In addition, we have in functional MR, the left ventricular pressures are increasing right at mid-systole because there is the two opposing forces, but the LV pressure, the closing force, is at its peak. And because of the shape of the geometry of this ventricle and the annulus, you also are seeing a closing, and therefore the flow is reduced right in the middle of systole. And in your PISA, you can see the smaller, the less dense quality to my CW Doppler. And we can go to 3D PISA, but again, the Doppler angle still is in effect. We can't escape that the lateral flows are still going to be 90 degrees, and we're not going to see the flow there. And so even on 3D PISA, we are not, it's still underestimating what the true PISA is. And we also know when we have mitral valve prolapse and you have late systolic MR, your single frame is going to overestimate your MR. So if you have on color a flow that looks the same, and the shape and the size of your EROA looks the same, you have to look at your CW Doppler. And here in mitral valve prolapse, it's mid to end systole, and therefore you're having a smaller regurgitant volume. So use the regurgitant volume more. It's more accurate when we're having in mitral valve prolapse. And of course, if you have an eccentric jet, ideally you're going to angle correct with this angle, because you have this constrained flow of your jet by the wall. Indirect method, you all know, and this is tough, even though the principle is very simple. What comes in must go out. So we measure what comes in, and then we see what is going out, the LVOT, and whatever is remaining is what's going back as your MR jet back into the LA. So this is just based on the continuity and conservation of mass. So you always have volume equals your area times your TVI, which is how far are you pushing that column of blood in one beat. So remember, there are a few caveats here. So when you measure your diameter, make sure you're going inner edge to inner edge and in early diastole. And you have to put your sample volume right at the annulus. You don't put it high at the tips. That's what we use when we're measuring for diastolic values. And when you trace your PW Doppler, we want to trace the modal velocity that has the most number average velocity and most dense line here, as opposed to when we're measuring for gradients, where you want the highest frequency and you measure at the edge. And so when we measure what is actually going out the LVOT in terms of stroke volume, again, we have to be very careful. We measure the diameter and we try to avoid calcium. Again, you must use and trace the modal velocity, the thickest, most line here. And you must also correctly position your PW sample volume right on the annulus, which is different than what we do for aortic stenosis, because in aortic stenosis, we want to go proximal to the flow convergence, but not when we're trying to measure stroke volume. And make sure you don't have significant AR. And then we can figure out, when we have already calculated the stroke volume that's coming in the mitral, through the mitral valve, and then what's going out the aorta, and then we have the MR. Now, we can substitute what is coming, the total volume that's coming in, by using biplane Simpson. However, we underestimate most often because we sometimes are foreshortened. It's better if you can use contrast. It will eliminate some of the underestimation of the true volumes. And of course, three-dimensional imaging is preferred, but this is not always possible in every everyone's lab. And again, what comes in minus what goes out is going to give us our total stroke volume coming into the LV, which is the same as what we calculated by using the diameter of the mitral annulus. Now, when we go to CMR, remember, there are no cutoff guidelines. And in our echo guidelines, we have with SCMR, there are no definite ones because this is all based on not prospective data. So it's observational data. And this was published by Dr. Garg. And you see that the moderate range is somewhere 30 to 60 in secondary, and he divided it up in primaries being smaller than that. And your MR volumes are a little bit smaller than what we're seeing in echo. So we do turn to CMR for quantification when we cannot determine really how much MR we have. Either our quality of our echo is not good, our Doppler doesn't coincide with our clinical picture, we have discordant values between what we did find on continuity and what we found on volumetric. And so then we go and try to see what the MR regurgitant volume is. And we look at the difference between what is actually coming into the LV and again, what is going out forward volume. And what remains is your mitral, just like we do for echo. Now, the trick is you have to pick the correct end diastolic volume, which has to be the largest, and then you have to trace the smallest volume, which is your end systolic frame. And as you can see in this diagram, people do not agree necessarily that is, which one, when they do the segmentation. So that's one issue. And then the second thing is we then calculate in a different way using phase shift contrast. Phase shift just means that those protons inside the water molecules are directly proportional to velocity, similar to what we're doing for Doppler. And when you subtract the two, you're getting the MR volume. And if you then take that volume and divide it by your total stroke volume, you're going to get a fraction. And why is there such a discordance between echo and CMR is that we both are measuring different things. And some of the papers that have come out show that if you have a late systolic jet, if you have multiple jets, or you have eccentric jets, it's very difficult. It does not really correlate, but you have to measure and still quantitate. And some of these studies did not really quantitate using Doppler. And so now we see that when we measure phase contrast flow in the aorta, we want to be as close as possible to the aortic valve, because as we move away from the aortic valve, this measured stroke volume actually increases from the distance, and therefore I will then overestimate, because I'm going to be now subtracting a larger number. And so I will overestimate my MR. So you have to be really careful, even though you're going to have some turbulence and aliasing, and you have to try to avoid that. In addition, it's very hard sometimes to see where is my annular plane, because there's so much movement and variation that I have flows going in both directions. And the excursion is so much from this higher stroke volume from the significant MR that I can overestimate my flows. And in addition, we don't actually necessarily measure this kind of prolapsing volume, because this is excluded from your end systolic volume. We're not measuring that routinely. Some labs are, because they've gotten aware of that this volume that is displaced inside the prolapsing leaflets this displaced volume or mitral prolapsing volume should be counted somewhere in the LV and systolic volume. Therefore, you will not overestimate your LV systolic volume or your ejection fraction. Another limitation that you must be aware of that is due to the magnetic field itself being not homogeneous. And while we pick a region of interest, we don't know if that is going to include eddies in the magnetic field that will cause phase shift errors. And if that happens, if you have one, that's fine. But if you have a lot, that can add up to be significant. And so you have to correct for that. So in conclusion, the number one important thing is to quantitate your MR, quantitate, and practice, because if you practice, you'll get better at it. It's important to know the strengths and limitations of both modalities from echo and CMR, because we want to quantitate because the best patient outcomes are related to that quantitation. We'll be more precise. And CMR is going to be helpful for us if our images on echo are not adequate. There's still discrepancies between the clinical picture and what we're seeing on Doppler examination. And sometimes CMR, if somebody has coronary disease, you want to look for viability at the same time. Also, there's a lot of data coming out on LGE and secondary or functional MR for prognosis. And both these imaging modalities are continuing to improve, which is helping all of our patients. Thank you very much.
Thank you so much, Ritu. I don't know if there is any question from audience. I can add some. Sorry, no questions?
I have a short question.
Okay, sure.
When you measure mitral valve stroke volume, do you have difficulties in quantifying the volume as too high, and then calculation is not good? The result of regurgitant volume is not good, and doesn't. We can compare with the stroke volume of the left ventricle, because the numbers are not appropriate.
Yeah, that can be a problem. And I think that the next iteration of 4D flow will overcome some of those difficulties. It's already being shown in various studies. We just don't have much prospective data on it yet. And we'll look forward to seeing if we can overcome it with that modality and not be so wrong in those cases.
Thank you. Any questions?
I want to ask one question and add a little bit comments. As you know, if there is no good pizza, vena contracta area is another option, and sometimes we can measure vena contracta derivated volumes to make better quantification. And 3D volume analysis is has very good correlation with CMR. Do you use it? Do you suggest it? And may I learn your experience?
I have used it, and I didn't put in those slides because it's not in the guidelines as it is, because there is a lot of variability between labs, and the cutoffs are not clear. They have been validated. For example, Steve Little's lab has validated some, but it is, not universally accepted because it's a small cohort. We don't know if that works over a long term, and we don't have prospective outcomes data. So that's why I left it out. But yes, I think that is also an evolving modality. And next time I'll put those pictures in to show you. And perhaps in the next iteration of guidelines, we will have that in there.
I think, and based on studies, 3D derivated stroke volume ejection fraction, and especially better than Simpson method. So Simpson method looks to me, maybe because of I am 3D fan, looks to me a little bit old-fashioned. And if we have 3D ejection fraction, 3D volumes, and we don't have MRI, I think a little bit better than Simpson method, right?
Yes, absolutely. And the Simpsons is what's, you know, in the 2017 guidelines, but of course we're in 2024. And ideally we should be using 3D volumes, which has been shown over and over again to be much more accurate and
Yes.
with prognostic information. So we should use 3D. Yes.
Thank you so much. Amazing presentation.
Thank you for having me.
We're moving to the next presentation. Professor Wasif from USA. The topic is the expanding mitral valve toolbox. What should I do with my patients? Professor Wasif.
Good afternoon, everyone. My name is Heba Wasif. I'm a cardiologist at the Cleveland Clinic, and I'm delighted to be here. Thank you very much for this kind invitation. In the coming few minutes, I will be describing the epidemiology of mitral valve regurgitation. I will outline the current options in management of severe mitral regurgitation and review current guidelines in the context of cases for both primary and secondary mitral regurgitation. 24 million people around the world are affected with this disorder, and this is data from the Global Burden of Cardiovascular Disease and Risk Factors, almost 4 years old now, and I do believe that this prevalence and estimates are lower than the true prevalence. Data from the Mayo Clinic shows us that mitral valve disease has a very high prevalence that increases by age, and almost 1 out of 10 patients over the age of 75 have some degree of moderate or severe mitral regurgitation. Both guidelines in the US and Europe emphasize the importance of identifying the etiology and mechanism of mitral valve regurgitation, as well as appropriate quantification, which was discussed by the previous speakers. Primary and secondary mitral regurgitations have multiple reasons, which I will not go through for this audience that's very well aware of the differentiation. The idea of prevalence of these different disorders, whether it's primary or secondary, varies depending on the population. And this is data from the Mayo Clinic from Olmsted County of 727 patients, an older population, aging 73 plus minus 18 years old, where we can see that functional mitral regurgitation is prevalent with a split between ventricular and atrial mitral regurgitation. And 30% of this cohort has primary mitral regurgitation, with 2% suffering from mixed mitral regurgitation and 1% was unknown. This will vary obviously by population. And with that, I start with my first patient, a 66-year-old man with history of hypertension, hyperlipidemia, and degenerative joint disease, who's known to have mitral valve prolapse since 2019 and has been monitored with surveillance echoes. Most recently, his most recent echo showed severe mitral regurgitation, but he remains asymptomatic and comes in for a second opinion. On his examination, he's hypertensive with a blood pressure of 151/83. And he does have a holosystolic murmur, mid-clavicular, extending to the axilla, and he was not in heart failure. His transthoracic echo, as we can see, shows preserved LV systolic function, a dilated left atrium, and bilateral leaflet prolapse, more anterior than posterior, with severe mitral regurgitation by color Doppler. As mentioned, it is a holosystolic murmur, which also plays into the severity of this regurgitation. The TEE 3D images reveal a myxomatous valve with a cleft between P1 and P2. And the question that the patient poses is like, what happens if I just wait? Well, this study, almost 18 years old now, try to address that issue. It's an observational study of 132 patients that were asymptomatic with severe mitral regurgitation, followed extremely closely with examinations and echo over a period of 8 years. And if the patient became symptomatic or they developed LV dysfunction or atrial fibrillation or pulmonary hypertension, they were referred to surgery. And as we can see that over the follow-up period, there was no difference in survival of this cohort compared to the expected survival. But what we are clearly observing is by the end of the follow-up period, there was significant percentage of events, meaning that event-free survival decreased as the patients were followed, and eventually at least half of the cohort had some form of an event, whether it was symptoms or LV dysfunction or new onset atrial fibrillation. So it is reasonable to follow the patient, but it has to be a very close observation, as with this cohort, as data from the Mayo cohort that I've mentioned on a previous slide does inform us that the expected survival of patients with severe mitral regurgitation is lower than their cohorts. So what should we do with our patients? Well, the timing of intervention has been clearly outlined in the guidelines. If the patient is symptomatic, it's a clear-cut case. They just need to have surgery. But if they're asymptomatic, if they have any evidence of structural abnormality, their EF is down less than or equal to 60%, or the ventricle is dilated more than 40 millimeters, then they need to undergo surgery to prevent further deterioration of the ventricle. If they're asymptomatic, such as this patient, and they have no structural abnormalities, what should we do? Well, if we're able to perform mitral valve repair with success and durability more than 95%, with a very low mortality, less than 1%, then it's reasonable to pursue surgery. And given that we are a center that fulfills this criteria, it was reasonable to recommend surgery for this patient, and he did undergo robotic mitral valve repair with a Duran band, annuloplasty, posterior sliding resection, and repair or closure of the P1 to 2 cleft with neocording. And I saw him in follow-up a year later. So what do we know about the outcomes of mitral valve repair versus replacement? This is 20-year outcomes after mitral valve repair versus replacement from the MITA, multi-center registry enrolling patients with degenerative mitral regurgitation in 6 centers across Europe and the US between 1980 and 2005. This cohort of 2,000 patients, of which 1,700 underwent repair and 200 underwent replacement, shows that mitral repair was superior to replacement. And in the overall population, the survival of patients who underwent repair was much higher compared to the patients who underwent replacement, 46 versus 23%. And with the matched cohort, this relationship was maintained. Repair remains superior, as well as the inverse probability of treatment waiting analysis that also showed similar results. So what is the risk of mitral valve repair for primary mitral regurgitation? Well, data from the US of almost 53,000 patients shows that the risk is very low. With the middle tertile, it's less than 5%, and in the 90th percentile, it's 1.6%. And as we can see on the right-hand side, that the risk remains low even in older patients over the age of 75. In the 50th percentile of this population of more than 75, the risk is less than 2%, even if there was a concomitant procedure. So this patient had undergone robotic surgery. So what are the contraindications for robotic surgery? Well, that includes left ventricular dysfunction, if there's greater than mild aortic regurgitation, aortoiliac atherosclerosis, if there is moderate or severe mitral annular calcification, small femoral vessels, pectus excavatum, and adhesion. So it's not suitable for patients who are undergoing redo mitral valve surgery. And this robotic procedure has been very successful at the clinic, with outcomes showing very low morbidity and mortality over the first 1,000 patients. In 2024, there's no talk that would be complete without identifying a role for AI. And there have been attempts to identify patients that would benefit from repair that are beyond the scope of this discussion. With that, I move to my second patient, a 79-year-old woman who comes in complaining with shortness of breath, and she does have a holosystolic murmur. And clearly on her TTE, it's a broad-based regurgitation, and with spectral Doppler, it's quite dense and significant, suggestive of severe mitral regurgitation. Her TE reveals a myxomatous valve with prolapse and flail A3 with a posterior directed jet. Further evaluation reveals a PISA of 0.68 and a mitral valve area of 5.2. Apart from her age, she did not have any significant comorbidities. She had very minimal coronary artery disease, and she had no lung, liver, kidney dysfunction. And therefore, she was offered surgery. However, the patient preferred that she would undergo TEER, or a mitral clip, in other words. So what is the data about the role of TEER in primary mitral valve regurgitation? Well, this was a study, actually the only randomized study to date that randomized repair versus surgery in primary mitral regurgitation, the Everest 2 study, almost 13 years old now, which randomized 279 patients to either surgery or TEER. I would like to note that this is a mixed population that included both primary and secondary mitral regurgitation, and the primary composite endpoint for efficacy was freedom from death, surgery for mitral valve dysfunction, or grade 3 plus or more mitral regurgitation at 12 months. And we had seen with this study that it favored surgery compared to repair, when including the subgroup analysis, except for functional mitral regurgitation. And shortly after the study, the mitral clip was approved for primary mitral regurgitation for patients who are high risk for surgery in the US. In 5 years, there was no difference in survival between the two groups, the device or the surgery group, but there were higher rates of re-intervention. So what is the Everest criteria, or what were the criteria that were used in the study? The regurgitation for primary mitral regurgitation was between A2 and P2. The mitral valve area was generous, over 4 centimeters square. The LV was preserved with an EF more than 25% and not dilated, with the end systolic diameter less than 55 millimeter, with a flail gap of less than 10 millimeters and a flail width of less than 15 millimeter, a coaptation length of 2 millimeters, and a coaptation depth of less than 11 millimeters. These would have been what is considered favorable. So what would happen if the patient underwent a clip and did not fulfill the Everest criteria? This is a cohort study of 59 patients that fulfilled the Everest criteria and 75 that did not. There was no difference in survival in the follow-up period. However, there were higher rates of re-intervention in patients who did not fulfill the Everest criteria. So there are clearly differences between patients, and it affects their outcomes, not the survival, but rather the needs for re-intervention. Our patient had a flail between A3 and P3, but her mitral valve area was quite generous, and therefore it was felt reasonable to pursue a mitral valve clip, which she did undergo and was successful initially, but a year later she did require surgical intervention given recurrence of mitral valve regurgitation. And as I mentioned, that the Everest study, the only randomized trial for TEER versus surgery in degenerative mitral regurgitation, is almost 13 years old, and therefore there are currently 3 ongoing studies: repair MR, mitral HR, and primary, of which the clinic is a site. These 3 studies include either moderate, high, or all comers. They have different primary endpoints, and they are randomizing patients either for a mitral clip or TEER versus surgery, and we hope to have results and more clarification for different populations that wish to undergo TEER for degenerative mitral regurgitation. As far as the guidelines stand right now, if the patient is symptomatic, they need to undergo mitral valve repair if possible, and if the risk is prohibitive, they undergo TEER, and if the patient is asymptomatic and their LV systolic function is preserved, and if the center is a high volume center, it is reasonable to undergo repair. And if they have any progression of their disease and they remain asymptomatic, it's also possible to undergo repair. That brings me to my last patient of this morning, or rather this afternoon, an 87-year-old woman with coronary artery disease who had undergone coronary artery bypass in the past with both tricuspid and mitral valve repair. Her EF is obviously reduced around 20 to 30%, and she's had a recurrence of her mitral regurgitation and underwent a mitral clip a couple of years prior to her presentation, and she was referred to our center due to worsening mitral regurgitation for possible reintervention. And before I inform you of what happened to this patient, I'd like to highlight the mortality benefits of GDMT that have been seen over the years, and they are put into perspective on the left-hand side, historically all the different drugs, and on the right-hand side, the mitral clip that I will discuss in the coming slides. Clearly, there is benefit from 17%, as was seen in the SOLVIT and CHARM study, up to 37% in the CARE heart failure, which involved CRT. But how does that impact mitral regurgitation? Data from BioStat study, an analysis of 1,000 patients, about 462 patients had moderate to severe mitral regurgitation at baseline, of which 42% of those patients actually improved with GDMT. So there is absolutely a role for GDMT in improvement of mitral regurgitation, and therefore it is a class 1 recommendation to improve GDMT prior to entertaining any other interventions. Of course, that is obviously time consuming for both the patient and the physician and requires a lot of work, as I do in my clinic, following a patient, bring them very repeatedly, almost every 2 weeks, as I'm up-titrating their medication. This audience is probably familiar with the outcomes of the COAPT and the MITRA-FR study, 2 studies that randomized the mitral clip plus GDMT to GDMT alone, with 2 very different results. With the MITRA-FR, there was no difference in heart failure or rather heart failure hospitalization or death, whereas the mitral clip plus GDMT had lower rates of death and heart failure hospitalization. And this improvement was maintained even in the 5-year analysis that was published recently. So what if a patient does not fit the COAPT eligibility criteria, but does undergo a mitral clip? This is cohort data from the TVT data set that shows us that patient that would not have been eligible for the COAPT study but did undergo a clip have higher rates of mortality and heart failure rehospitalization to the COAPT eligible patient, but they do benefit from a quality of life. Therefore, there is some value of placing a clip, even though the results may not affect the mortality of heart failure hospitalization. But it's important to set the standards and the expectation for the patients with shared decision making. The exclusion criteria for COAPT, there were multiple exclusion criteria for COAPT, almost 28 variables, of which the inclusion criteria and exclusion criteria were included in the guidelines that would recommend TEER if the patient has an LV ejection fraction between 20 to 50% and an LV end systolic diameter less than 70 millimeters and a pulmonary artery systolic pressure less than 70 millimeters, meaning that severely dilated ventricles or severe pulmonary hypertension would not be reasonable candidates. Is there any role for surgery? in ischemic mitral regurgitation. This is a randomized study that randomized replacement versus repair, which shows no difference in survival, but does show difference in higher rates of recurrence in the repair compared to the replacement group, almost 58% versus 4%. So the current guidelines recommend intervention for secondary mitral regurgitation after GDMT has been attempted, and mitral valve surgery would be recommended if the LV systolic function is more than 50% and the patient remains symptomatic with severe mitral regurgitation. If the EF is less than 50% and we've up-titrated their medication, TEER is reasonable, and if they have persistent symptoms, then surgery would be attempted. And that brings us to what happened to our patient. She did undergo CRT with marked improvement of her mitral regurgitation. And to wrap up, it's important to identify patients' clinical criteria and mitral valve anatomic elements to determine success of an intervention. Repair is superior to replacement in primary mitral regurgitation. TEER is inappropriately selected patients with primary mitral regurgitation is reasonable, and there are ongoing studies to determine outcomes when TEER is pursued versus surgery. And TEER in patients with secondary mitral regurgitation is attempted after appropriate GDMT. I hope I have achieved my objectives of describing the epidemiology of mitral valve regurgitation and outlining the current management strategies in both primary and secondary mitral regurgitation. And thank you very much for your attention, and I'm happy to take any questions. Thank you.
Thank you, Professor Wasif. Thank you for your nice presentation. You cover a full spectrum of different types of mitral regurgitation and what to do in every patient. Can I ask you, do you have cases with repair of the mitral valve, functional mitral regurgitation, who present with a new moderate to severe mitral regurgitation, because we have such a patient in our clinical practice, and I think that the reason for this is that we didn't analyze sufficiently the function of the left ventricle and size of chambers, geometry. What do you think?
Well, first of all, thank you very much for the invitation, and I'm sorry my video is not working, so I'm glad I had taped it. And I'd also like to mention what a wonderful presentation Dr. Taman had preceding my talk, as well as Dr. Soraka. I've been enjoying it all morning. It's always a challenge. I think and I do have also patients that have failed the mitral clip, especially like 2 to 3 years out. And I go back to trying to identify, is there any way to optimize their medical management? Can you up-titrate them? And it is a challenge. And I'm currently actually up-titrating medication with a patient in my clinic, where we're bringing her back almost every 2 weeks to try to up-titrate her medication with frequent labs. And it is time-consuming and cumbersome for the patient. Before we entertain a repeat intervention, as you said, I mean, because the more clips you have very limited room. So you come back to GDMT prior to entertaining a re-intervention. And if you fail after 3 months, then you have to go back to the drawing table and reassess, are they suitable for a re-intervention.
Thank you. Indeed, good medical therapy is a must in our patients. Thank you. Are there questions from the audience? Comments? No other questions. Thank you. Thank you, Professor Wasif, for your nice lecture again. And we move to the next presentation.
The next speaker will be Professor Papadopoulos Kostas from Greece. He will speak about the imaging in for mitral valve in valve procedure. Costas, good afternoon. Nice
Good
to see you
afternoon.
here.
Can you hear me?
Yes.
Yes. Professor Christova, congratulations once again for this great meeting of ECHO. I'm sad that I'm not there, but I will try to be next time. I enjoyed a lot the previous talks, and I would like to make a comment to Professor Kinova about the case she mentioned, that after the presence of a ring in mitral valve repair cases, if the gradient and the MV area is measured adequate for edge-to-edge repair, then one option could be transcatheter edge-to-edge repair. Okay, implant a clip. Otherwise, I will show you other transcatheter options of mitral valve in ring. But of course, I agree with the previous talk that even in cases that will undergo edge-to-edge repair, it is necessary to, first of all, to titrate the medication and go with guideline-directed medical treatment, because this will affect the outcome even after edge-to-edge repair. So always optimal medical treatment and then different transcatheter options. So let me share my screen and proceed to my presentation. Can you see my screen?
Yes.
So we will talk about the imaging for mitral valve and valve procedures, the preoperative planning, and of course the intraoperative guidance for imagers. We heard before that there are many reasons why a patient cannot undergo a surgery or a reduced surgery. There might be comorbidities, a low ejection fraction, or very old people. And we know that mitral valve is not aortic valve. We have two asymmetric leaflets. We have the subvalvular apparatus. We know that the mitral valve changes size and shape during systole. It is very proximal to the LVOT. We have the chordae, the papillary muscles, and it's very difficult to proceed to transcatheter replacement. Hopefully, we have different treatment options that target to the annulus, to the leaflets, or direct replacement of the valve. And in this lecture, we will focus on the transcatheter options for mitral valve replacement when it is a redo case with a biprosthesis or a ring. Of course, we have to mention that we have transcatheter devices like the Intrepid valve, the Tendyne or Alta valve, and different other valves that are that target at a native valve replacement. And we will focus in mitral valve in valve and a valve in ring. Valve in MAC is another category where you go to a very calcified annulus, mitral annulus, and you implant a valve with the transcatheter options. And we know from this old VIVID registry that we have different access options like the transapical or transfemoral with a transeptal puncture. We can implant the valve in the mitral position with a hybrid form with a direct left atrial access or from jugular vein. But of course, we prefer the transeptal approach with a transfemoral venous access because we have the less complications. So we know from previous studies that there is no difference for mortality between transapical and transeptal access, and we have a huge difference in mortality when it comes to valve in valve and valve in ring procedures. And as you can see from this study, for valve in valve procedure, the all-cause mortality was around 70%, and for valve in ring, it was around 30%. This TMVR registry also confirmed that the 1 year mortality in these transcatheter procedures is around 30% for valve in ring and 14% for valve in valve. And this difference comes from the rate of embolization of the valves when they're implanted in a ring, and the higher rates of paravalvular leaks after implantation. This trial also showed that the 30-day mortality after valve in ring was around 10%, which is acceptable. It's very close to the surgical risk. And in valve patients, the 30-day mortality was 6%, which is, of course, it's a very low rate of surgical risk if you take into account that all these patients are of high surgical risk, which means that they have a 30-day mortality of 10% or more. This mitral trial also included patients with valve-in-valve and valve-in-ring with transseptal approach, and they showed very good results in 1-year follow-up. Valve-in-valve cases had the survival of around 97%, and valve-in-ring patients had the survival of 73%. And this editorial compared different registries and trials, the MITRA trial, the TVT and TMVR registry, the VIVID registry, and a review, a case series from Urena and their team. And they found out that valve-in-valve had the best technical success in 1-year follow-up, with less mortality and LVOT obstruction and mean gradient. And valve-in-ring also had a technical success of around 80% with acceptable rates of mortality and complications. So far we know that redo cases with mitral valve replacement or repair have a high surgical risk of an STS score of around 10% or more for 30-day mortality. So it is feasible to proceed to transcatheter mitral valve implantation of always a balloon expandable valve, SAPIEN, or even MyValve. It's a new valve. Never go with a self-expandable valve. And we know that since all heart teams gain experience, the rates of mortality and complications are even less than 10 years ago. What is the role of the imager? The imager plays a crucial role in these interventions because he has to assess the patient and for the pre-procedural planning, guide the procedure during the implantation of the valve, assess the final result, of course, follow up the patient. For pre-operative planning, we have to assess all these parameters, and we have to check, first of all, the valve. If it is a stenotic mitral valve or a regardless mitral valve, then we have to assess the approach, a transapical approach with thoracotomy, or a transatrial hybrid approach, or a total transcatheter approach from a venous transseptal puncture. So transfemoral venous access and transseptal puncture to reach the left atrium. Of course, we have to check the sizing of the valve that has the biprosthesis that has dysfunction, or the ring that has been implanted before, and we have to check for LVOT obstruction after the implantation of the valve. All these parameters should be assessed, concomitant valvulopathies, of course, and the function of the left and the right ventricle. For pre-procedural planning, as you can see here, this is a patient with mitral valve repair with a failure and relapse of significant MR. We always go with a CT scan to measure the dimensions and the area of the ring, and there are some applications that suggest the size of the valve that needs to be implanted according to the ring that we have implanted before. And this is an information that we need to know, because there are some rings that are suitable and there are others that are unsuitable. And we know that we can definitely reject patients that have a complete rigid ring, but the ideal patient is the one with a complete semi-rigid ring. Complete rigid rings cannot change their shape, so at the end they will deform the SAPIEN valve, the balloon expandable valve, and this will create, of course, high gradients and a severe paravalvular leak. semi-rigid rings change their shape, and as you can see, they become circular after the implantation of the balloon expandable valve. And it is debatable whether we can implant a valve when we have a band or an incomplete ring. In these cases, we are not sure that the valve will not embolize or not. So it is debatable. And this list shows in general which rings are suitable for valve in ring procedure and which rings are unsuitable for valve in ring. What we need to do, what we need to measure is the area of the rings and of course the minimum and maximum diameter. And we take these measurements with a cardiac CT, or if we have a nice 3D TOE, we can, as you can see here, we can have a nice image of the ring and measure the area and the minimum maximum diameter. LVOT obstruction is another issue. We have to check the septal bulge, if the septum is very hypertrophic, or if the angle between aortic and mitral valve is too acute, and if we have a small left ventricle or an elongated, of course, anterior leaflet. In these cases, we might produce high gradients at the LVOT and obstruction, and these patients do not have good outcomes long term. In such cases, if we have an elongated anterior leaflet, we might use the Lampoon device for a small cut of the anterior leaflet, and this will prevent LVOT obstruction. And of course, with several applications with cardiac CT or 3D TOE, we can measure the predicted neo-LVOT, which if it is more than 170 millimeters square, then we know that we do not produce LVOT obstruction. And as an example, this is the case that you should reject for valve ring implantation. You can see the patient with a small cavity, a hypertrophic septum, and a small angle between the mitral and the aortic valve. This patient is not suitable for valve in ring implantation. We can take these measurements also with MVQ analysis for mitral aortic angle. Guidance is also very important. So once we decided that the patient is suitable and we have our measurements from cardiac CT or TOE, then it is important to guide the procedure. Of course, for valve in ring, a fluoroscopy plays also a crucial role, because we have fluoroscopic markers of these balloon expandable valves, and you can also appreciate the level of the ring or the valve. So for the procedure, first of all, transeptal puncture is very important. We have to go to the superior vena cava. So we use two projections, the bicaval view and the short axis view. Bicaval to go superior, close to the superior vena cava, and short axis view to move away from the aorta. We have to go posterior. That way, we measure the distance from the tending we create at the septum towards the level of the annulus, and this distance for valve in ring or valve in valve should be more than 3.5 centimeters. Then we have to guide the wires and the catheters, the wires towards the pulmonary veins with 2D and 3D echo, and in fluoroscopy, the interventionists have images like that. Septostomy is very important because otherwise our catheter will not cross the septum. We use a balloon of around 12 millimeters of diameter usually. And these are fluoroscopic images of the deployment of a sapien valve into a ring. And you can see that we have to implant the valve. The 80% of the valve should be deployed into the ventricle and 20% should be deployed into the atrium, because otherwise the valve will embolize during contraction of the left ventricle. And this is the final result, which has to be confirmed, of course, with TOE, because fluoroscopy will not show PVL or will not measure the gradients of the valve correctly. So we have to check the final result. And I will show you this case that we did it last week. A 64-year-old male patient. He was previously operated with aortic valve replacement due to AR with a bioprosthesis and CABG. He had a severe dilatation of the left ventricle, which caused tethering of the mitral leaflets and severe secondary MR. During the operation, the surgeon thought that it was better to also implant a mitral ring. And unfortunately, we had a relapse of MR during the first month of follow-up of this patient. The patient became symptomatic again, so the heart team decided to proceed to mitral valve in ring. Just to mention, the baseline mean gradient of this mitral valve was more than 5 millimeters of mercury, and the measured area of this ring was 2.8 centimeters square. So this was a stenotic valve, and this patient was not suitable for edge-to-edge repair. And here you can appreciate this is the first TOE before the aortic valve implantation and the mitral valve repair. You can appreciate both severe AR and a significant functional MR due to tethering of the leaflets. This is the TOE after the operation, the surgical operation, where you can appreciate the presence of the ring, aortic valve replacement with a bioprosthesis, and significant remaining MR, and the patient being symptomatic again. So we decided for valve in ring implantation. Again, we go with transfemoral venous access. We go up to the right atrium, biplane images of short axis view and bicaval view to go posterior and superior. And we cross the septum with an SLO catheter into the left atrium. We advance the wires into the pulmonary veins and our catheter into the left atrium. And then we have to proceed to the septostomy with a balloon of 12 millimeters in order to open a hole in the septum and then cross the delivery system of SAPIEN valve. And here you can see the moment of septostomy with a balloon, and that created this little hole, this defect of the septum, which can be appreciated with this photorealistic 3D method. And then we advanced the valve. You can see here, this is the SAPIEN valve across this ring in the mitral position. And this is the deployment of this SAPIEN valve into the mitral position. This is biplane views of the mitral valve. Unfortunately, we had this significant paravalvular leak, which with the surgeon's view, we appreciated to be at 9 o'clock. We decided to perform a post-dilatation with a balloon. Here you can see the post-dilatation with fast pacing. And hopefully we had a perfect result. The PVL disappeared, and this was the final volume rendered color and 3D color views and biplane views of the valve. And the valve was functioning well with normal mean gradients, no PVL, stable in its position. And of course, the follow-up is up to us, the imagers. We have to check the mean gradient of the valve, remaining PVL, and of course, the gradient of the LVOT. We can accept a mean gradient of the valve according to the dimensions and the size of the valve up to 9 or 10 millimeters of mercury, which sounds a bit high, and it might show mismatch of a valve in a patient. But however, the average mean gradient for this valve, these valves is around 5 to 7 millimeters of mercury. And this was the final result in our patient. You can appreciate here the SAPIEN valve in the mitral position. It was far away from the septum. We didn't provoke any obstruction, and the mean gradient of the valve was 5. So in conclusion, we have different options for transcatheter mitral valve replacement, even in redo cases that have a failed bioprosthesis or a relapse of MR after mitral valve repair. A valve in ring is strongly recommended, especially if we have a team with great experience. we try to eliminate the complications, and the mortality is similar to is similar to the 30-day mortality of the reduced surgery, but better in long-term follow-up of the patients. And of course, we need imaging skills and a nice heart team, a strong collaboration between the imagers and the interventionists. And this October, again, with Professor Badano, we ran our 6th course of hands-on 4D echo course. So you are all welcome to come and join in Thessaloniki. Professor Christova, thank you for the kind invitation again.
There is no questions, but if you have time, can you tell me which of kind procedures do you prefer, to valve-in-valve or ring-in-valve? Valve-in-ring.
So I cannot. It depends on what the patient has in advance. If the patient has a bioprosthetic valve, then valve-in-valve will be the option. If it has a ring, valve-in-ring will be the other option. If you ask me what is better for these patients, it might be better to go with valve-in-valve because the embolization rates are lower, and the valve stays in its position, and maybe PVLs are lower as well. But in primary MR, surgeons usually go with repair, with implantation of rings, and we always suggest to go with a semi-rigid complete ring to give the option to the patient afterwards, maybe 10 years later or even more, to proceed to a valve-in-ring procedure. Otherwise, if there is a band or an incomplete ring, we don't have the option to proceed to valve-in-ring. But I guess edge-to-edge repair would be the other option in this patient.
Thank you. Thank you so much. So we will move to the next presenter. I will invite again the Professor Tuba Kemaloglu, if she is here, still there.
Yes.
Okay.
Here, can you see me? Okay, our last presentation, Abdullah Al-Maghrabi from United Arab Emirates. He will talk about he will talk about cardiography for tricuspid valve structural procedure. Abdullah, can you hear us?
Good afternoon, everyone. It is my pleasure to share my presentation today in Echocardiography Days, Sofia 2024. It is my first time to participate in this great meeting, and I would like to thank the organizing committee for the invitation, specifically Professor Krasimira. And also, as I'm representing the Global Society of Cardiology, I'd like to thank the President of Global Society of Cardiology, Professor Tuba. My talk today is about the echocardiography for tricuspid valve structural procedures. I have nothing to disclose related to this presentation. First of all, we need to know that severe symptomatic tricuspid regurgitation nowadays affects millions of persons worldwide. However, because most of the cases are secondary regurgitation, the benefit of surgical correction of this isolated secondary tricuspid regurgitation remains controversial, because we know that there is an increased risk of periprocedural mortality, periprocedural morbidity, and periprocedural complications specifically. But in recent years, there were novel transcatheter tricuspid valve interventions that were introduced into the market. So the tricuspid valve interventions now is considered in symptomatic, inoperable, or high surgical risk, and anatomically eligible patients. And actually, it can be divided, all the interventions can be divided into certain groups: age-to-age leaflet repair, annuloplasty, caval implants, spacers, and we reached the level of tricuspid valve replacement, the whole valve replacement. So as we know, the interest in the tricuspid valve has increased over the past 2 decades because there is a recognition of the progressive nature on the clinical impact of the secondary tricuspid regurgitation that occur in many of patients, either valvular heart disease patients, heart failure patients, etc. And in recent years, these novel transcatheter tricuspid valve interventions were developed for treating this TR specifically. So we know that the current European Society of Cardiology and the European Association of Cardiothoracic Surgeons guidelines for the management of valvular heart disease consider the transcutaneous tricuspid valve interventions in symptomatic and inoperable or high-risk patients who meet anatomical criteria for eligibility very important. So next step to know is the tricuspid valve anatomy. The largest valve of the heart actually is the tricuspid valve. And its normal orifice area is like 7 to 9 centimeters squares. And the most it is the most apically located valve. We define the tricuspid valve because it is more near to the apex of the heart. And the valve has 4 main elements. Okay, the first element is, from the anatomical point of view, the first element of the valve is the tricuspid annulus. But this tricuspid annulus is considered by many, specifically surgeons, that it's considered like a virtual structure because it is just connecting the right atrium and right ventricle, in which there is no continuous ring of fibrous tissue. So this annulus is virtual, not a real annulus, specifically when you are talking with surgeons. Then we have 3 valve leaflets. The 3 valve leaflets, as we know, are one, a septal leaflet, anterior leaflet, and posterior leaflet. Okay, we can have another nomenclature. So there was novel tricuspid leaflet nomenclature because most of the leaflets are not 3, and sometimes also some of the leaflets have scallops. So the smallest leaflet, which is attached directly to the septum, is the septal leaflet. Okay, this is one that is on the ventricular side of the AV junction. The septal leaflet is the smallest one. It arises directly from the tricuspid annulus above the interventricular septum, and it is connected to the septal wall through small, short chordae. Okay, so the least mobile leaflet of these leaflets, when we see the tricuspid valve in echo, either transthoracic or transesophageal echo, is the septal leaflet. So the modern anatomy textbooks, especially surgery textbooks now, they published many reports that suggest that the number of leaflets may vary. They are not 3. Sometimes they are 2 by fusion of 2 septal and the posterior leaflet. Sometimes they are 4, and sometimes they are 5. Why? Because some commissures must be defined at first, and these commissures can divide the single leaflet into many parts. Next, the chordae. The next part is the chordae, because all leaflets received chords from the related papillary muscles in the right ventricle. And the septal and the septal wall gives chordae to the anterior and septal leaflets. Okay, and there are many other accessorial cords arising from the right ventricular free wall, and sometimes the moderator band that we all have can be directly attached to the leaflets. We all know this moderator band. The final thing to consider is that the view of the tricuspid valve is not 2-dimensional, and the 3-dimensional reconstruction with modern technology of the tricuspid valve can show that it is a non-planar saddle-shaped pattern with 2 high points that corresponds to the anteroseptal and the posterolateral segments, and 2 low points corresponding to the anterolateral and posterior septal segments. So the annular shape now changes during the cardiac cycle, being circular in diastole and ovoid or oval shape in systole. Consequently, the annular size is maximum in late diastole and the minimum in mid systole. So in patients with functional tricuspid regurgitation, the tricuspid annulus is flatter, which reduces the saddle shape. Compared with normal subject, patients with functional tricuspid regurgitation have a more circular annulus and greater enlargement in the anteroposterior rather than in the mediolateral diameter or distance, because the greater dilatation occur along the free wall side of the annulus. And in the presence of tricuspid regurgitation, the percent reduction of the tricuspid annulus size during the systole is also significantly decreased. Therefore, the minimum systolic annular dimension is almost twice larger than in normal subjects. Here, we are trying to see the novel tricuspid regurgitation classification, the novel tricuspid leaflet nomenclature, as I told you, novel approach to imaging of the tricuspid valve, and novel tricuspid valve quantification of tricuspid regurgitation. We all know that the functional tricuspid regurgitation may be atrial, like in patients with atrial fibrillation, with remodeling of the right atrium, and ventricular, like in patients with right ventricular failure. So here the leaflet restriction is in systole because there is right ventricular abnormal function. Maybe also device related, and here the leaflet restriction is in systole and diastole. And finally, the organic or primary tricuspid regurgitation, such as in rheumatic heart disease. The proposed tricuspid nomenclature, here we can see the proposed tricuspid nomenclature as the type 1A here, type 1, with septal leaflet, posterior leaflet, anterior leaflet. Here we can see septal leaflet, posterior, anterior leaflet. This is type 1A in 3D and in 2D. Then the type 2B here is anterior-posterior fusion of anterior-posterior fusion leaflets and the septal leaflet. So the regurgitation here will not be central. It will be at the site of the septal leaflet. And the type C, which is called the type 3A, 3B, 3C, the type 3A is the presence of two scallops inside the anterior leaflet, two scallops inside the posterior leaflet, which is called now 3B, and two scallops in the septal leaflets. It will be called the 3C. So the septal leaflet now looks like, and the tricuspid valve now looks like a quadricuspid valve. And finally, the type 4 here in F, we can see that there is two scallops of the posterior, two scallops of the anterior, and one leaflet septal. This will cause, like you can see, a valve with 5 leaflets, P1, P2, A1, A2, and S, which is a septal leaflet. So there is proposed tricuspid nomenclature now in this paper. I recommended to read actually in order to know about this tricuspid nomenclature. Then the multimodality imaging of the tricuspid valve. We are talking today on echocardiography. Echocardiography is important in qualitative tricuspid regurg assessment, in semi-quantitative tricuspid regurg assessment, and estimation of pulmonary pressures. Then the assessment of transvalvular pacemaker leads and the relation to the tricuspid valve in patients with cardiac devices. And finally, the quantitative tricuspid regurg assessment with effective regurg orifice curve. So here we can know the regurgitation volume, regurgitation fraction, and we can confirm by MRI. Here we can know the volumes and functions by echocardiography, and we can confirm by CT also. Regarding the quantification, as I told you, we have many quantification methods for the tricuspid regurgitation. We all know, actually, with PISA method, 2D method for tricuspid valve diastolic stroke volume, effective regurgitation orifice area calculation, 3D method, and the effective regurgitation orifice area calculation by 3D methods, forward stroke volume, which is used to quantify the regurgitation volume, and you can know the diffusion volume by knowing the LVOT diameter and LVT pulse wave Doppler to know the cardiac output and the stroke volume, and the 3D vena contracta area. Here also the rule of three-dimensional echocardiography. This paper is very popular actually, which helped a lot in the three-dimensional echocardiography imaging in tricuspid valve, and it can be a guide for every echocardiographer who is interested in the tricuspid valve quantification and tricuspid valve interventions. Actually, we have the full volume from the transthoracic approach with volume rendering of transversal couplings from both ventricles and atrial aspect and ventricular aspect of the tricuspid valve. And there is also full volume from the transthoracic approach with volume rendering of the longitudinal cut planes here. And we can see the full volume with multi-beat acquisition from the transthoracic approach to slice mode or 3D construction in order for proper measurement of the tricuspid annulus and the measurement of the right ventricular and the tricuspid annulus size and shape of the tricuspid annulus. And also this full volume color Doppler in order to know the size and shape of the regurgent jet vena contracta. And finally, full volume multi-beat acquisition from the transthoracic approach of surface rendering to know the right ventricular volumes, the stroke volume, and ejection fraction. What about transgastric views? What about the transesophageal echocardiography? Actually, transesophageal echocardiography has a very limited access to the tricuspid valve because the tricuspid valve is an anterior structure because it lays in the right ventricle, which is almost forming the anterior wall of the heart. But it can help. But mainly, the tricuspid valve is better being seen by transgastric views. And this paper actually is showing that transgastric imaging or transgastric views by transesophageal echocardiography is a key for the successful periprocedural T-guiding for age-to-age repair for the tricuspid valve. Here we can see the mid-esophageal views for the tricuspid valve RV inflow and outflow view. Okay, that can show you the right atrium, right ventricle, anterior leaflet, posterior leaflet, left atrium. And this is the deep transesophageal also inflow and outflow views in order to see the right ventricle, right atrium, and anterior and septal leaflet here. And finally, the transgastric views in order to see this short axis, like the surgeon view, septal leaflet here, anterior leaflet here, and posterior leaflet here. Then we will proceed to see what are the options, as I told you, for transgastric tricuspid valve interventions. The options, as I told you, direct suture annuloplasty, like Tri-Line device, direct ring annuloplasty, like Cardioband device, coaptation enhancement, like age-to-age repair with TriClip or Pascal device, Tri-Cinch and Forma devices, and finally, valve replacement, whole valve replacement, like Trach valve, which is considered a valve inside the superior vena cava, TRICA, and Navigate. This paper by Professor Agricola and colleagues that was published in JACC Interventions, JACC Cardiovascular Imaging in 2021 for imaging for tricuspid valve interventions, repair and replacement, actually is like a guide for everyone who is interested in tricuspid valve interventions. Another device to show you is a Cardioband device. Also, this is a guide by echocardiography. What is the rule of echocardiography? System insertion navigation to the right atrium as every case. Implant deployment of the Cardioband through the mid-esophageal views, deep esophageal views, biplan imaging, multiplan reconstruction, and fluoroscopy for sure. Then the pull test. We pull on this device in order to see if the ring is shortened or not, and the tricuspid valve annulus is shortened or not. Then to implant size adjustment and the cinching, and finally seeing the reduction of tricuspid regurgitation. Here we can see the device coming into the tricuspid valve, reaching the tricuspid valve annulus, and then we are going to cinch every part of the Cardioband. As you can see here, every part of the Cardioband is inserted into the tricuspid valve annulus, but it near the edge of the valve leaflet itself. And here is also the wire inside the right coronary artery in order to avoid any injury to the right coronary artery. And then it's final insertion of all the band cinches, and then pulling the cinches together in order to decrease the size of the ring. Finally, you can see after pulling the wires that the tricuspid regurgitation is reduced from this to this. Another device is a Tri-Line device. Actually, it is like the Tri-Cinch, but with only one anchor here. And then we pull the wire, and then the wire is jailed by this stent inside the inferior vena cava. So the echo here is used to guide the placement into the RV, and then reaching the tricuspid valve, catheter insertion advancement in the right atrium navigation, then anchoring the implant deployment here, anchoring it. Maybe also you can use fluoroscopy, angiography, and also the multiplan and intracardiac echocardiography we can use. Then tensioning pool test to see the degree of reduction of the annulus site and degree of reduction of tricuspid regurgitation, then stent deployment system removal, and then assessment of tricuspid regurgitation. Here we can see also, this is a place where we can put the anchor inside the tricuspid annulus here, and the device is coming from the inferior vena cava. Then we are pulling, and we can see the leaflet before here, before pulling, before tension, and here after inducing tension. Here we can see we are inducing tension and releasing the stent in order to gel the wire inside the inferior vena cava. And finally, we can do like coronary angiography to the right coronary artery in order to see if there is any injury to the coronary artery because of its near proximity to the valve. Finally, I will show you the last case because I think I have limited time. Here also we can see this TriClip device. This is also an edge-to-edge repair device. We can know by the pre-intervention echocardiography plan the procedure by knowing which leaflets we are going to clip. Then the echocardiography also will guide you through the insertion into right atrium navigation, advancement into right atrium and steering navigation through the 3D infus view, 2D mid-esophageal views, fluoroscopy, then axial alignment of the clip and the clip arms orientation by pipeline, and the 3D infus view of the tricuspid valve. Then grasping of the leaflets, and we can confirm the grasping of the leaflets through the transgastric views because we can see well the leaflets itself, either by the transgastric short axis view or long axis view. Then assessment of leaflet insertion, and then the result evaluation before and after clip deployment via color Doppler and continuous Doppler. Then system removal and assessment of the tricuspid regurgitation degree. Here we can see the access through the right atrium to the tricuspid valve. Then we can reach the tricuspid valve leaflets. Here's also the inflow-outflow view of the right ventricle. Here's also showing the orientation of the valve, clip in relation to the valve. Another confirming the orientation and grasping of the clip arms to the leaflets we are talking here is AL and SL, septal leaflet and anterior leaflet. And finally, through confirming through the deep transgastric views, and then we can release the clip. Here we can see the conversion of the valve from one orifice into a figure of 8 or 2 orifices now. Okay, we can see here the conversion from one orifice into 2 orifices and the figure of 8. So finally, my take-home message is that the echocardiography is the cornerstone imaging modality for tricuspid valve interventions. And 2D and 3D transthoracic echocardiography and transesophageal echocardiography, as well as intracardiac echocardiography, are our tools here. And we need echocardiography in patient selection, finding the proper device, planning the procedure, procedural guidance inside the procedure, during the procedure, and then follow-up later on. Thank you so much, and hope to see you in person next year.
I want to highlight shortly that the configuration of tricuspid valve is very important, especially after 3D evaluation. We can understand tricuspid valve better, and just watch and follow strategy is not okay. We should think tricuspid valve, and we know that increased surgery risk make some difficulties to solve patients. So TriClip and other percussionist procedure is really very promising. We passed the time, so I want to close session. And I would like to thank all speakers for amazing presentation and my co-chairs for their great contribution and audience for questions and being part of this amazing session. As a global society of cardiology, we have more than 10,000 members, And we organized the first Metaverse Congress last year, and this year we are going to organize first case report competition. And it will be held in Metaverse again, and on 25th May 2024. I am happy to invite you, and I hope to see you face to face soon. Thank you so much.